Today's lecture will be on muscular strength and endurance. So here's our objectives. We want to display an understanding of strength, power, and endurance, identify different types of muscles contractions and their use in rehabilitation, discuss the differences in open kinetic chain and closed kinetic chain activities and the advantages for use in rehabilitation. We'll discuss the SAID principles and the importance in sports rehabilitation. We'll identify different forms of resistance, use, and advantages and disadvantages of each. We'll discuss neural component of early rehabilitation. We'll know the key elements of exercise prescription. We'll display an understanding of factors that determine levels of strength and endurance. And we'll discuss our theories of muscular hypertrophy. So muscular strength is defined as a maximum force a muscle or muscle group can exert. Power is strength applied over a distance for a specific time. And so our equation on that is power equals force times distance divided by time. And then muscular endurance is the ability of a muscle or a group of muscles to perform repeated contractions against a less than maximal load. So you see that athletes need a combination of these three. Some need more muscular endurance, some need more power, and some just need more strength. So a power lifter is mainly going to need power. A long distance runner is going to need more muscular endurance than they're going to need power. A high jumper is going to need more power than they're going to need muscular endurance. So we need to be able to apply this to an individual athlete based upon their needs. So an isometric contraction means the same length. So no change in muscle length occurs. It is isolated to 20 degrees within an angle performed. So if you're doing, let's say, a biceps contraction at 90 degrees of elbow flexion, then we're going to have to also work at 70 degrees and 110 degrees to be able to gain strength through an arc. So we're only going to gain strength within that 20 degrees. We're going to gain strength if the effort is from 66% to 100% of maximum output. So you can't really just get much out of it if you're barely putting any effort into it. And that's kind of the hard thing with this. It's without some type of strain gauge, it's measuring the amount of force that the athlete is putting out with this. It's kind of hard for us to know where their maximum is and if they're putting forth enough effort to make a gain. But within a week, you can get a 5% gain. But the problem of it with just a single day of inactivity, you can lose that 5% that you just picked up. So consistency is the key there. Isotonic contraction, which means the same tension, so the tension is unchanging. So it's dynamic that it involves a change in the muscle's length. We have a concentric and an eccentric component, and our functional activities and sports performance use a combination of both of these and in varying degrees. Coordinated movement requires muscles to work synergistically across a joint. So as an agonist contracts, the antagonist eccentrically contracts. So if I'm doing elbow flexion and I'm moving my hand towards my face, I am actively concentrically contracting my biceps, but on the other hand, the triceps muscle, the antagonist, is eccentrically controlling that motion. Because without that antagonist, and I just fire my agonist, then my hand is just flying up towards my face without any control. So that synergistic motion between the two muscles, the agonist and antagonist, gives us that quality of movement that we need, especially with sports performance. So concentric is the muscle shortening, the eccentric is the muscle elongating. So the eccentric can produce more force, 20 to 40% more. The concentric requires more energy, but the force production decreases with speed, whereas the eccentric force production increases with speed. So if you're doing a concentric exercise, you want to make sure that you're going nice and smooth and controlled on that. But your eccentric ones, you can really pick up the pace and get a lot more speed with it. So that's one thing to remember as we do different exercises. So we have no difference in the two in regards to strength gains though. So some people, they think because you're getting that 20 to 40% more force with eccentric that it's more important to do eccentrics. Really, it evens out in the end. Then here's a picture of an isokinetic machine. So you've probably heard of maybe a Biodex. Kincom is an old one you probably have never heard of, probably in a museum somewhere. Um, but this is not a functional way to do exercise because that's not how we move. We don't move at the same speed or same motion. The problem with it is it's expensive or requires a lot of setup. You see that kind of old school computer there that it's hooked up to, and it takes up a lot of space. And so for those reasons, it's really not used much. It was used pretty extensively and quite popularly through the 80s and maybe even into the early 90s. By the time I was starting my career in the mid 90s, it was kind of on its way out. By the 2000s, I was pretty much hadn't seen these anymore. Research still uses them. It's a good way to measure your strength, peak torque, hamstrings to quadriceps ratio, and you compare it side to side. So you do both legs. So you do the affected leg, you do the unaffected leg, and then that computer there spits out a whole printout of these measures. And so it used to be, especially with ACLs, we use this for return to play. So if these people had a 85, 90% side-to-side peak torque of their quadriceps muscle, then the physician would say, okay, they're ready to go back to play. Again, that's really not a real functional way to determine a return to play, though. So let's talk about open kinetic chain exercises. This is where the distal segment of the extremity moves. So a throwing motion, a kicking motion, you create more velocity with this with less force. So throwing a ball doesn't require quite nearly as much force, but it creates a lot higher velocity. And so it allows us to focus more on a single muscle or a single group of muscles. And then closed kinetic chain activities are where the distal segment is weight bearing and the body moves over it. So an example is a push-up or a squat. These tend to be more functional. You get a co-contraction that results in less shear force on the joint, makes them safer earlier in rehab. So you can get folks doing mini squats right after an ACL as soon as you can get them weight bearing enough that they can do a short squat, mini squat, or like somebody after a total knee or total hip. So remember that it's safer earlier in rehab because it produces a co-contraction resulting in less shear. The problem is that it also may allow substitution for weaker muscles. So you may get somebody that's substituting that's fairly subtle, and you really have to watch and make sure that they're doing the exercise properly. So now is the SAID principle, so specific adaptation to imposed demands. So each sport and each position within a sport have different demands. So you see our two examples here in the pictures. You have a gymnast and you have a baseball pitcher. So the demands placed upon their bodies cause their bodies to adapt. So you see how much external rotation this pitcher has. So he probably has, that's probably close to 160 degrees. 90 is normal for an average person. Probably your throwing athletes, your overhead athletes, 120 is probably not out of the realm of the ordinary. But a pitcher, because of the torque that he places upon his shoulder, will get this excessive external rotation. And typically along with this, they'll also have a loss of internal rotation at the shoulder. So it's just based upon the demands that he's placed upon his shoulder. So the gymnast to the right, so the question you might wonder is she a gymnast because she has such great hypermobility through her spine, or is her spine developed hypermobility to the point that she's able to do this through her training? So I would say it's probably a combination of both. One, based upon her body morphology, may have led her into the sport of gymnastics. And then her training over time led to this great amount of trunk extension that you see in the picture there. So our rehab needs to provide exercises that are specific to the injured player's sport or position. So you're not going to rehab a baseball pitcher the same way that you're going to rehab a volleyball player. You're going to do things specific to their sport, even though both are an overhead athlete. They both are in a different position whenever they are performing their sport, so they have different demands that are placed upon their body. So you want to work in specific movement patterns or part of the motion based upon the demands of the position. So let's talk about different exercise methods. So we can provide resistance manually, where we're able to place resistance through a range of motion, and we're able to adjust our resistance. So as you feel them starting to fatigue, or maybe they're stronger than you anticipated, you can increase the resistance so you cause the fatigue to occur a little quicker. You're also able to feel whenever they're substituting. You're able to work through just a particular part of the range of motion. You can also work isometrically, focus on the eccentric component. Again, like with the baseball pitcher, you may want to work more on that eccentric component as the arm comes across the body during follow-through to slow the arm down. The manual treatment or therapy or resistance is cost-effective, but it's time-consuming. So if you have 6 athletes in your athletic training room, you're maybe not going to spend a lot of time doing manual strengthening with each of them. But if you have somebody one-on-one, you may want to spend more time with them in that. You can use body weight, and body weight's great because there's minimal setup required. It's cheap, it's cost-effective, and it's functional. This is how we move. And you can adjust the intensity, you can alter the center of gravity, the base of support, the line of gravity, you can adjust the speed. Body weight exercises are really great, and I use a lot of them. The popular rainbow colors there to the right of the TheraBand, the TheraTubing, you get multiple planes of motion, and you can utilize PNF or plyometrics with it, and it tends to be functional. We can use machines. There's advantages and disadvantages to the machines. They're safe and easy to use. They can be expensive, but it does constrain the motion. So you're working generally in a single plane of motion, so you're not getting necessarily as much co-contraction around the joint. You're not getting as much neural input to the exercise. Then you always have free weights there, and these don't restrict the motion. You do have a higher degree of neuromuscular control. The problem with these, it does have a little bit of element of risk of injury. You have to make sure you have a spotter and those type of things. So with our therapeutic exercise, we may have weakness that's due to reflex inhibition. So reflex inhibition occurs following an injury or after a surgery. So what happens there is that the muscle won't do its job because it says, if I do my job, it's going to hurt. And so I'm not going to do it. So you'll sit there and you'll tell that quadriceps to fire, and it won't do anything. So we have to reconnect the brain to the muscle, because the muscle quickly then forgets what it's supposed to do. So if you have somebody with great big thighs, and you saw them in the weight room the previous day, and let's say they maxed out at 500 pounds on their deadlift, but then they injured their knee the next day in practice, and now they can't even lift their leg up. Is the weakness due to the muscle fiber not working, the muscle fiber not being there from atrophy? No, they just within a few hours had plenty of strength, had plenty of muscle fibers there. It's more the neurocontrol. So the neural activity is decreased because of the reflex inhibition. So the initial emphasis in our rehab, in our therapeutic exercises, we want to facilitate the neural elements of an atrophied muscle, or we want to prevent the atrophy to occur by facilitating the neural elements. So you see from the graph here, you have strength gains on the vertical and you have time on the horizontal. So you see a rapid increase and then a kind of slower increase, and then it plateaus off or levels off. So those initial gains are typically attributed to the neuromuscular recruitment, the efficiency, the coordination, and the motor unit re-education. Same thing goes with weight training. You get somebody that hasn't weight trained, you throw them in the gym, and all of a sudden they're making these great gains, and then they're making fewer gains, and then they kind of level off. Same thing is they're kind of a motor learning type of thing. They're getting more recruitment, motor unit education on what they're supposed to be doing. So our exercise prescription. So exercise is medicine. You go to the doctor with something, the doctor writes you a prescription. He tells you what to take, how much of it to take, the frequency to take it, and the duration. How long are you going to take this medicine for? The problem is we are prescribing medicine, but we don't necessarily know how much to do, how long to do it. And so we've got to be able to determine those things based on the tissue that's involved, the severity of the injury, which phase of healing they're in, and the attitude of the athlete towards their injury and their recovery. So we've got to be able to synthesize all of those things and make up our exercise prescription. So based on this information, you'll determine which specific exercises you'll need to do, how many reps and sets, the frequency, the recovery time, and the rest. I once heard a well-respected physical therapist say that the rest that we get after our activity is just as important as what we do. So we want to make sure that that our athlete understands that they're getting enough rest. I know that's kind of difficult in a college situation, but also we need to adjust our prescription based upon that if we need to. I always tell my athletes and my patients the 24-hour rule. So if we do something today and you're sore, especially joint soreness, and it lasts longer than 24 hours, you've overdone it and you need to pull back. If they're just muscle sore, I don't get as worried about it. But if they have stiffness, edema, loss of range of motion, joint soreness, I'm really concerned about that, and I'm going to pull back a bit and realize I've overdone it. If they have a little bit of soreness that resolves within a few hours, that kind of tells me that I've done it about right, because we've got to hit that middle ground. If we don't do enough, the tissue's not going to change. If we do too much, the tissue's going to change for the negative, and we're going to have a negative result. So we got to really hit that sweet spot where we get them a little bit sore, but it goes away within that 24-hour frame. That way we're changing the tissue, and the tissue will adapt, and then the next time they come in for treatment, we're able to do a little bit more, and then continue that progression without having any setbacks. So a number of things determine the levels of strength and endurance. So the size of the muscle, this is kind of a gimme. That's the proportional to the cross-sectional diameter of the muscle. As you have a greater cross-sectional area, you have greater size, you have greater strength, and greater force production. Kind of makes sense. Somebody with big muscles is probably going to lift more weights than somebody that has smaller muscles. So hypertrophy is an increase in muscle size. Atrophy, as we know, is a decrease in the muscle size. 2 on the factors that determine levels of strength is the number of muscle fibers. So the number of muscle fibers is an inherited characteristic. So again, a person with a large number of muscle fibers has more potential for hypertrophy than someone with fewer muscle fibers. So you have somebody that shows up to campus that's never lifted weights, that's well built. Guess what? He's probably going to hypertrophy much quicker than somebody that shows up to campus that's kind of skinny and thin and not as well muscularized. The third one is neuromuscular efficiency. So strength is directly related to efficiency of the neuromuscular system, and the efficiency is enhanced in three ways. One is the number of motor units recruited. Two is the increase in firing rate of each motor unit, and then the synchronization of the motor unit firing. And then biomechanical considerations. So the position of the tendon attachment. So the closer that the attachment occurs to the fulcrum of the joint, and the greater resistance and the greater the force produced. And then fifth is age. So as we age, as we go through puberty and adolescence, we gain more strength. This peaks at about 20 to 25. And then after the age of 25, our maximum strength declines about 1% annually. So what causes muscular hypertrophy? So we have three theories. One is hyperplasia, where you get an increase in the number of muscle fibers. These are determined genetically, so it doesn't seem to change just by training. Increasing the number of capillaries is kind of correct. We don't create new capillaries, but we may have dormancy of capillaries, and so the activation increases their activity to meet the new activity level of the muscle. Oops, went the wrong way. And then the third, which is most likely the answer as for hypertrophy, is increase in size and number of myofilaments. So you know that the muscle is kind of looks like a cord wrapped by a number of cords, which is wrapped by a number of cords, which is wrapped by a number of cords and wrapped into a big muscle. So you have, going from greatest to least, you have the muscle, and then you have the muscle fiber bundle. Inside that, you have the muscle fibers. Inside of that, you have the myofibrils. And then lastly, the smallest unit is the myofilaments, which are the actin and the myosin. And then the myofilaments will increase in number and size, causing the muscle fibers to increase in cross-sectional diameter. The problem with hypertrophy is that it is highly reversible, and atrophy will begin within 48 hours. So that is our lecture for today, and I hope you enjoyed it. If you have any questions, bring them to class. We'll see you next class period.